Okay.
Okay, so good morning, everyone. Today I'll be talking about neurological manifestations in SARS-CoV-2, and my name is Hala Sultan. Okay. So just as a kickstart, we'll start talking about SARS-CoV-2 in general. It's an enveloped positive stranded RNA virus from the beta coronaviridae family. Corona comes from the Latin word meaning wreath or crown. And as you can see on the electron microscopy, you have these spikes coming out of corona. And this is a TEM image also of corona showing the spikes. And then this is a colored one. So the green part is actually the spikes giving it its name. So the coronavirus it tends to mutate and adapt quickly to cross-species barriers, and there are many types of coronaviruses, such as the SARS-CoV-2, which caused a pandemic sometime in 2002, the SARS-CoV and SARS-CoV-2, and then there's the MERS, which caused an epidemic, and these usually originate from a zoonotic transmission. So just a briefing on the mechanism for viral replication. The virus targets a receptor for attachment and it gets internalized. And this receptor is called the ACE2 receptor. So what happens is the RNA gets released into the cytoplasm and it's subsequently translated and replicated. The envelope protein is formed and then the RNA is incorporated into this virus and released off into the circulation. Okay. As we all know, there are many systemic manifestations for COVID-19. Asymptomatic and mild cases account for about 80%. Severe cases are about 14%, and then the critical cases, those requiring ICU admission, are about 5%. For individuals who develop symptoms, fever is the most common. This is followed by cough, fatigue, sputum production, shortness of breath, sore throat, and headaches, respectively. As for the CNS, there's a pathophysiology for CNS invasion. So ACE2 receptors are found in the CNS. So SARS-CoV-2 can enter into the CNS and affect neurons and glial cells in the brain and spinal cord. So what happens is it either enters via retrograde invasion and then goes up through the olfactory epithelium, the cribriform plate, and the olfactory bulb to enter the CNS. And this takes about 7 days to occur. Or it can directly disrupt the blood-brain barrier and invade the brain directly. Or what can happen is it can go through the peripheral nerve terminals and then through the synapses move upwards into the central nervous system. It can either indirectly enter via hematogenous spread or from inflammation in the CNS can disrupt the blood-brain barrier and enter. There are mechanisms for secondary CNS damage. And these include hypoxic brain injury and immune-mediated injury. So hypoxic brain injury is when you have severe pneumonia and it results in hypoxia and therefore brain damage. So this is largely due to peripheral vasodilation, hypercarbia, hypoxia, anaerobic metabolism, and accumulation of toxic compounds that results in neuronal swelling and edema of the brain. Or, as we said, immune-mediated injury, which is due to cytokine storms with increased levels of inflammatory cytokines and activation of T cells, macrophages, and endothelial cells. So what happens is there is release of interleukin-6, there is vascular leakage, activation of the coag cascade, and as we commonly know, these patients suffer from DIC and eventually end organ damage. So in general, these are the COVID-19 neurological manifestations. The neuroinvolvement can be a result of direct invasion or indirect effects due to hyperinflammation, and we'll just talk about these in more detail as we go. So the most common, accounting for about 30 to 80%, are anosmia and ageusia, and these affect the peripheral nervous system. So anosmia is loss of smell, as you know, and is thought to be due to congestion of the nose, which leads to loss of the fine hair-like endings of the olfactory receptor cells due to inflammation and structural damage. So they become ineffective in picking up odor molecules. And this is why some people actually complain of a loss of smell even post-viral infection. There's also ageusia, and it's due to its loss of taste due to the tongue having a very high expression of ACE2 receptors in comparison to both the buccal and gingival mucosa, and therefore poses a higher risk for viral binding and taste receptor damage. About 77% of patients complain of headache and dizziness, and they are non-specific and minor symptoms of many diseases. These are partly believed to be secondary to raised inflammatory mediators in the body and decreased cerebral blood flow from hypoxia and endothelial changes from viremia. There is also central respiratory failure. And so we said the SARS-CoV-2 infects nerve cells and also infects the medulla oblongata. And it's actually believed that some respiratory symptoms from the SARS-CoV-2 is secondary to respiratory center involvement. And therefore, autopsy findings actually say that patients with CoV-2 show brain stems that are hyperemic and edematous with neuronal degeneration. There's also acute inflammatory demyelinating polyneuropathy or myelitis, and this was seen in 6 reported cases. Patients either had Guillain-Barré syndrome or diseases that fall within the Guillain-Barré spectrum, such as Miller-Fisher syndrome and polyneuritis cranialis. These patients present with fever and body aches, later with acute flaccid paralysis or bilateral bilateral lower limb sensory loss and urinary and bowel incontinence. They can also present with quadriplegia and bilateral facial paralysis. And this is believed to be due to the neuroinvasive, obviously, nature of the virus and due to a cytokine storm and overactive inflammatory responses that is evident by the elevated serum ferritin, C-reactive protein, serum amyloid A, and interleukin 6. There was only one case that reported acute necrotizing hemorrhagic encephalopathy, and patients presented with altered mental status. It was believed to be due to an intracranial cytokine storm, which resulted in direct blood-brain barrier breakdown without direct invasion or para-infectious demyelination. Other patients presented with encephalitis or toxic-metabolic encephalopathy. So encephalitis was seen with patients presenting with altered mental status, seizures, and unconsciousness. And this was basically due to the demyelinating process as one of many etiologies. This is an MRI of one of the patients. It's a DWI and ADC image. And it just showed the widening of the ventricles in both images, as well as high intensity signaling of the splenium of the corpus callosum. Seen here, okay. Additionally, there was toxic metabolic encephalopathy, and it was most likely seen in patients that suffered severe respiratory symptoms and had to be given high doses of anesthesias and sedatives as part of their symptomatic management. It was also believed to be due to hypoxia and viremia as possible factors behind this. Okay. About 0.5% of patients suffer from strokes, and it is believed that the more severe the infection, the higher the D-dimer levels, and the more likely these patients developed strokes because the virus gained access to cerebral circulation, bound to ACE2 receptors, and caused endothelial rupture and thrombus formation. It's also believed that the slow cerebral circulation compared to the systemic circulation poses an increased risk for the viral replication and rupture. This is a CT angiography here of a 33-year-old woman. She presented with fever and cough, and upon CT angiography, they found a microthrombus in the common carotid artery and near the bifurcation of the internal carotid artery. So she was proven to have COVID-19 as well as a stroke. About 0.5% of patients also suffered from ataxia with unclear pathophysiological mechanisms, but it's believed to be secondary to breached blood-brain barrier and involvement of the brainstem, or due to elevated inflammatory markers. About 0.5% of people also had seizures, but this is not because the virus primarily caused seizures, but because it decreased seizure threshold secondary to innate immune responses from cytokine surge. Since we've had a lot of small fiber neuropathy patients in the clinic, I actually looked up small fiber neuropathy in association with COVID-19 on PubMed, Science Direct, and Google Scholar, and there was only one case report, which is actually a post-COVID-19 syndrome. This reports a 64-year-old female who already had orthostatic cerebral hypoperfusion syndrome and small fiber neuropathy, and it was well controlled. 1 year after being well controlled, she developed she had COVID-19, she was infected with COVID-19 and then redeveloped symptoms of orthostatic cerebral hypoperfusion and small fiber neuropathy. So this was the only confirmed case of small fiber neuropathy. Additionally, patients have neuropsychiatric symptoms such as depression, psychosis, insomnia, and mood changes. A lot of healthcare workers and survivors of COVID-19 suffered from PTSD, panic attacks, and anxiety. Aggression and frustration have also worsened with the quarantine and lockdown procedures. I've looked up diagnosis and investigations of CNS manifestations, and there were 2 articles. So the earlier article believed that you had to isolate SARS-CoV-2 from cerebrospinal fluid, and that autopsies clarified the role played by the virus in causing these neurological manifestations. However, the more recent article said that all the current information we have about neurological manifestations is in the context of avoiding advanced neurodiagnostic procedures like MRIs, lumbar puncture, electromyography, and nerve conduction studies. And this is due to an attempt to reduce the risk of cross-infection within hospitals. I've also looked up treatment, and obviously there's no treatment except for supportive treatment. So I decided to talk about challenges instead of CNS involvement. So we all know that the CNS has dense parenchyma, and its imperviousness not only protects the brain from infection, but once you have an infection, it becomes very difficult to eliminate it. So cytotoxic T cells are the mainstay for viral elimination at this point. And with more research and earlier diagnosis, we might be able to overcome this problem. So in conclusion, SARS-CoV-2 may present in various manifestations, including CNS symptoms. These may be in the form of anosmia, ageusia, central respiratory failure, etc., all of the ones I've mentioned. And due to fear of cross-infection, there is a limit in the use of advanced investigation and diagnostic tools. And that concludes my presentation. These are my references, and thank you.